Again, I'm professor of economics at the University of Hawaii, and I served as like a chair, vice chair, and Asian team leader of national transfer accounts. And my study focused on issues related to population aging, labor market, social welfare, health issues, with a special emphasis on Asian economies. I'm very happy to serve as moderator, MC, and chair of this session. So the session's title is Harnessing Demographic Dividend and Silver Economy and Implication to a Health System. The demographic transition opens a window of opportunity. So during the demographic transition, there is a period when the share of working population increases. They actually produce more than they consume. So they save as well, and they are productive people. So we call it first the demographic dividend. And also during the demographic transition, there is an increase in capital. Capital can be two forms, whether physical capital or human capital. And the human capital increases because the fertility declines, and household parents can invest more on their children, leading to second demographic dividend. For example, my mom had 9 siblings, and I have only 1 sibling. So that's natural to increase human capital, so-called second demographic dividend. But second demographic dividend can be a form of physical capital. People live longer and healthier. They prepare for their retirement. So they save more, and this saving can turn into investment, leading to second demographic dividend. Some people, including myself, actually named this another one, third demographic dividend or silver dividend. So people live longer and healthier, and so older people have now, these days, have a huge health capacity work. So they are very active. But the system doesn't change, right? So retirement age is 65 or 62. But this increase in life expectancy, especially healthy life expectancy, leads to so-called third demographic dividend or silver dividend. And also they are consumers, so which lead to so-called silver economy. So again, first, second, third, or silver dividend, plus women are more likely to participate in the labor market during the demographic transition for many reasons. Number one is of course, a decline in fertility. So which in turn lead to so-called gender dividend. Again, to my best knowledge, these 4 dividends are called demographic dividend. But this demographic dividend is not automatic, never. Just increase in share of working population does not lead to first demographic dividend. People, of course, live longer and healthier, but many older people don't work. So we cannot harness so-called silver dividend. And also, countries have a very different stages of their population transition. Some countries are still on the first demographic dividend stage, some countries on second, and some countries like Korea or Japan are on the third demographic dividend stage. So, but that's not sequential. This is actually, especially in Asian countries, these all demographic dividends are happening at the same time. It's very, very rapid. So, depending on the stage of transition, policy focus would be different. So I have observed that some countries focus on more like harnessing third demographic dividend and raising their retirement age. Some countries, especially African countries, still focus on the harnessing the first demographic dividend. And many countries in East Asian countries or many Asian countries are still focusing on the second demographic, harnessing the second demographic dividend. However, for all stage of demographic transition, good health is very, very important factor of harnessing, realizing the demographic dividend. So it must be maintained as it is a key driver for demographic dividend. Having said that, this session delves into the dynamic interplay between health, silver dividend, demographic dividend, identifying the actionable strategies for health systems, investment on children, and support the system for the elderly, pension system to leverage the opportunities and mitigate the challenges. So I have a speaker profile here. We have 4 excellent speakers in this session. From far left, actually, I asked them to sit there because it is always like from left to right. Okay, so that's the order of a presentation. So Ms. Aisata For is a policy dialogue specialist on demographic transitions and social policy with over 25 years of experience leading multi-country programs across Africa. So I look at her resume. It's amazing. She works with the Population Reference Bureau. She coordinates a high-level policy dialogue linking government, parliament, researchers, academia, and civil society to advance gender-responsible budgeting, social protection, and care economy reforms. And the second presenter is Mr. Boradon Ledrat. Is a Director of Research and Policy Partnership at 101 Policy think tank in Thailand. So he has also very extensive experience in public policy research at Center for European Studies at Chulalongkorn University in Thailand, and the Future Intelligence and Strategy Unit at National Institute of Development Administration in Thailand. And actually, I found his education background very interesting because he attended the top universities in Netherlands, Spain, and Czech Republic. So I don't know whether he can speak Dutch, Spanish, or Czech, but it's an interesting background of education. So he'll obviously talk about young people, the experience. And our third speaker, Mr. Philip O'Keefe, also known as PIB, is a professor of practice at the University of New South Wales Center for Population Aging Research, also known as CEPAR, right? So he leads a policy research program in societal aging in Asia, covering issues from macro, fiscal to labor market, social protection, healthcare, silver economy, actually everything. So he has a lot of experience in Asian countries. So whenever I go somewhere, I see very often actually Eduardo, Pim, and many other people, Wasana too, and Odd. So, and also he's very well known for his work in the World Bank. So he has a lot of experience with other countries as well. Last, on my right, Ms. Kanoko Oishi. So she's the CEO of a Midiba company and director of a community and community hospital association. So she founded this Midiba company, but it's a consulting company specialized in healthcare. But it does not only provide consulting services, but actually also develops and operates its own healthcare and senior care services. So she knows the real world. So it includes elderly daycare services, focus on functional training, medical care services, and so on. So it's actually my honor to have these 4 excellent speakers who can talk about, demographic dividend, youth, older people, and the women as well. So that's a very nice composition and combination. Okay, I think I talked too much. So without any further ado, let me invite Ms. Aisata For first. Okay, for the podium. You can actually talk there or here, whatever. Probably here. Yeah. Okay.
Hi, everyone. Thank you for being there. So my name is Aisata Fall. I am based in Dakar, Senegal. And I spent the last 3 decades working on providing evidence and to different policy-making stakeholders, which means not only high-level decision makers, but also civil society and any other people that are in the society that needs to understand how decision-making is defined. So I've been asked to talk about silver economy, which was quite funny because I work on the care economy, which is something very new in Africa, and I come from social protection, and I discover all that unpaid care work stuff thanks to the NTN network. So thank you, I think, and it really revealed to me a new way of thinking our future and our past in Africa, and also how to bring new elements, including economics, into this rights-based dialogue and social policy design usual way of working. We often talk about the demographic dividend on one side and the silver economy on the other, and in Africa, these two dynamics are already intertwined. And one important question is how health systems transform this trajectory, either into a positive dividend, again, or into a debt. And the demographic dividend and the silver economy are not two separate agendas, but one single trajectory. The silver economy or aging economy refers to this set of economic activities linked to the needs and capacities of older populations. It is often presented as a market opportunity, yet it actually rests on health, income, and autonomy trajectories that are built long before the old age. So when we talk about the demographic dividend and the silver economy, we still tend to think in terms of two separate words. On the one hand, youth, employment, and future growth. On the other, aging, dependency, and healthcare cost. And this separation is not only conceptual, it's also very institutional. Demographic dividend frameworks mobilize ministries, expertise, and instruments and time horizons focused on youth and the working age population. And aging and silver economy frameworks, by contrast, are structured around pension, dependency, long-term care, and market-oriented approaches to older population. In Africa, these two agendas are neither sequential nor separable, they are already overlapping. And this overlap is placing health systems under strain. The challenge, therefore, is not to simply implement policies for the demographic dividend today and prepare for the silver economy tomorrow, which is most of what I see in terms of programmatic thinking while we are talking about preparing the future through policies. The challenge is really to understand a single trajectory of which today's decisions are already shaping the condition of aging tomorrow. So this overlap is explained by a mismatch between two distinct transitions. The demographic transition, so it refers to the change in population age structure driven by declined fertility and increasing longevity, and the health transition, which refers to change in health and disease profiles, so declining early mortality followed by a rise in chronic diseases, disabilities, and long-term care needs. In Africa, fertility is declining, sometimes quite rapidly, due to urbanization, girls' education, access to contraception, and broader social change. And this decline is real, so still incomplete and highly uneven across countries, regions, or social groups. The health transition, however, is progressing more slowly and is far more demanding institutionally. So gains in child survival and maternal health have been substantial. Yet, health systems remain insufficiently prepared to prevent, detect, and manage chronic diseases, mental health conditions, disabilities, and long-term care needs across the life course. And the life course is really the main word, not thinking on acute episodes, but thinking that something is going to happen later and we need to be prepared. This means the early risks are increasingly managed, while later risks remain largely unaddressed, and as a result, fragile health trajectories emerge. Larger cohorts reach adulthood and later life with degraded health capital, and untreated conditions. Aging thus begins in a context where the silver economy is not a natural horizon, but a growing pressure on households, on women, and on health systems. This configuration highlights a frequently underestimated point. The demographic dividend is presented as a future opportunity while its costs are immediate. The first immediate cost is a mechanical increase in demand for services. A large and young population, so in Africa, 70% of the population is under 35 years and 50% is under 20. So a large and young population means more pregnancies, more births, more children, and more adolescents. Even as mortality rates decline, the volume of service required rises sharply, placing immediate pressure on infrastructure, health workers, and budget. The second immediate cost is the increasing complexity of health profiles. Countries do not replace one problem with another, they accumulate them. Infection disease, malnutrition, and maternal health remain priorities, while non-communicable diseases, mental health conditions, injuries, and lifestyle-related risk emerge earlier. Our system must manage a double burden without adequate human resources and financing mechanism. The third immediate cost is the degradation of future human capital when continuity of care is not ensured. If health investment stops after child survival, cohorts enter working age larger in number but more fragile. And the last but not the least, the fourth, often invisible immediate cost is the transfer of responsibility to households. When health systems do not cover needs, families compensate. So the cost in time, income, and in health is borne disproportionately by women, and we come to this. African health systems are not passive beneficiaries of demographic change. They are one of the main mechanisms through which it is transformed into either a positive demographic returns or into weak and fragile outcomes. When health systems ensure continuity of care across the life course, healthy human capital is built. Large cohorts reach working age with higher productive capacity, delayed morbidity, and later dependency. When systems remain fragmented and focus on acute episodes, degraded health trajectories result. So individuals enter illness earlier, lose productivity sooner, and reach dependency faster. So demography creates an opportunity, creates a potential, and health systems determine whether that potential generates positive returns or no returns or negative returns. Investing in child survival, maternal health, and basic care is a major achievement on my continent. But when this investment stops too early, without consolidation now across the rest of the life course, health systems inherit 2 decades later a large but fragile population. The expected demographic returns do not simply disappear. They turn negative, becoming a health, social, and fiscal debt that is shifted onto households and future generations. This explains why the term dividend is used. Because when I'm not an economist, I'm not a demographer, okay? I'm the kind of guinea pig that say to all these bright people, very interesting, but actually I don't know how to use that. I don't know exactly what it means in the real life and how policymakers are going to understand it. So this term of dividend has been used so many times until I was like, why is this word of dividend? And it's really interesting to explain to people why this language is used and what there is behind. So this word is used because it refers to a potential return from favorable age structures. But like any dividend, it is neither automatic nor guaranteed. We have to be sure that there is a favorable environment to get it. In this context, a silver economy becomes a test and not a promise. Global narratives often assume older people who are healthy, autonomous, and financially secure. This vision rests on an implicit assumption: continuous investment in health across the life course. In most African countries, aging begins without this preparation. Even as both life expectancy and healthy life expectancy increase, gains in longevity do not automatically translate into robust, well-supported aging trajectories. And when the silver economy is not supported by robust health trajectories, what keeps the systems afloat is not a sector, but a form of work. It is care, which is largely unpaid. If you're asking whether Africa is ready for the silver economy, you're asking the wrong question. The real question is, what today's aging about health reveals about health care and cost have been distributed over time. It's really looking today to understand what happened before and what we have created. Health outcomes do not depend solely on clinical acts. They also rely on daily, continuous, and often non-technical functions: treatment adherence, long-term follow-up, accompaniment, mobility support, nutrition, hygiene, psychosocial care. When these functions are not provided by formal care services or structured pathways, they are absorbed by households, specifically by women. Unpaid domestic and care work supports both children's human capital accumulation and the care of older person. It forms the invisible infrastructure that makes the demographic dividend conceivable and aging seemingly manageable. This infrastructure is deeply gendered. Unpaid care work is disproportionately performed by women, directly affecting their labor market participation, their incomes, their health, and their access to contributory social protection. In West Africa, women spend on average 13 hours per week on unpaid care work compared with about 4 hours for men. This effectively positions women as the primary buffer through which health and social protection system absorb unmet care needs. In effect, health systems function partly by externalizing care-related costs onto women's invisible labor. And this externalization weakens the productive and contributory base needed to finance stronger health and social protection systems, and it undermines both the first demographic dividend and the conditions for sustainable aging. African health systems were designed to address acute episodes. They are far less equipped to manage long trajectories, so chronic illness, aging, dependency, and home-based care. This architecture systematically shifts continuity of care outside formal systems. Unpaid care work becomes a functional component of health system and also unrecognized as health work. It conditions healthcare effectiveness and long-term sustainability. So without adaptation, there is a risk of a double generational failure. A failure toward younger generation that occurs when mental health, reproductive health, and prevention is neglected, degrading human capital precisely at the moment it should be consolidated. A failure toward older generation when aging translates into widespread unsupported dependency. This failure is gendered. Women who have borne disproportionate care burdens throughout adulthood are more likely to reach old age without independent resources and with prolonged dependency. And these outcomes are not accidental. They reflect how costs have been distributed over time. So the question, therefore, is not whether a country is ready for the silver economy. This framing, in my opinion, is misleading. The silver economy is not a model to be implemented. It is the cumulative outcome of budgetary, health, and social choices. An intergenerational transfer perspective makes this visible by asking who paid, when, and for whom. Which costs were shifted to household, to specific generations, and to women. And tools such as national transfer account, national time transfer account, and demographic dividend-sensitive budgeting are critical here for us, as they reveal that not investing in health and care today is not a saving. It's just a postponement of cost to tomorrow. Harnessing the demographic dividend and managing aging require genuine coordination across health, labor, family, budget, and social protection sectors. As long as health remains isolated, it will continue to just manage the consequences of decisions made elsewhere. This is why the demographic dividend, often framed as an economic opportunity, and the silver economy, often framed as a market, are in practice tests for health system. Countries that invest early in health care and women can transform demographic change into sustainable development. Those that do not, like a lot of countries in my continent, will transform aging or are already transforming aging into a health, social, and fiscal crisis. And that choice is being made now, not in 20 years. Thank you.
Hello. Okay, thank you. Thank you for excellent presentation. Her presentation argues that Africa's ability to harness the demographic dividend and silver economy depends a lot on the, health system reform, and it should be from the perspective of a life course. So of course, rather than treating youth, aging, and care as just separate policy agendas. It makes perfect sense because. Health is a cumulative investment, right? And then past dependent. But at the same time, you argue that the long-term healthcare raises an issue of a burden of care and the fiscal pressure. And in addition, the most unpaid, this care work is largely carried by women, which is a direct implication on their labor force participation and everything, right? So demographic dividend. And I liked your picture of women says 13 hours and men says 4 hours. That's enough. Okay. So our next speaker is Beradon, Mr. Beradon Redrat. Actually, he doesn't have a PowerPoint, so the floor is yours.
Thank you very much. Thank you for having me today. I'm Verdon Ladrat. I'm a young researcher representing youth voices on the topic of silver economy and demographic shift today. So I expect to learn from our panelists and our participants today. What I'd like to share is from the context of Thailand. I work in the youth policy research think tank in Thailand that try to build the policy knowledge and communicate to youth and populations to empower people to make political and policy decisions at best. From the context of Thailand, I think that it's interesting that youth is usually expected to be the powerhouse to empower the economy among the demographic shift. But nowadays, I think that it will work. This expectation will work only if youth is well supported and well prepared to have enough human capital to empower the economy. But in Thailand, it's not that case, right? Let me start with some context. Thailand is the first Asian non-high income countries that become old age society. So it means that we become old before rich, which is opposite to many age society that become rich before old. And that makes it's very challenging for youth to accumulate the human capital to empower the economy in this situation. Theoretically, I think that these, the latter demographic dividends that our moderator referred to at the beginning of the session are based on an increase in financial and human capital accumulation. However, the saving level in Thai society is very low, and most elderly in Thailand lacks of savings and investments. Actually, according to the statistic of the National Statistic Office, less than 10% of population aged 60 years old and above have main income sources from their own savings and investment and contributory pension. Actually, half reports no savings at all. And another half, 2/3 of another half, report the total amount of their saving less than 100,000 baht, which is equal to only a few months of middle class monthly salary in Thailand. So it's impossible to cover their entire retirement, not to mention that saving and that saving can become the investment in the society and for the young generation to thrive on. So in this context, the largest group of the elderly depends on the support of their children, the grandchildren, or their younger relatives. And hence the increased old age population means more dependence on the working population and even more in the future on youth, rather than have some savings and resources that can be foundation that youth and economy can thrive on. And another problem of like Thai age society is that the lack of human capital, actually throughout all ages and all generations. But for the elderly, if we expect that the elderly can lead the silver economy, actually only, I think that it's only around 15% of population age 60 and above graduated high school or higher education. So I think that they can contribute quite little to the new growth engine, the high skill growth engine in the silver economy. And it's quite difficult for them to upskill and adapt to the new reality. And the fact that Thailand is not a high income country also implies that the economy is very low productive and it's full of low income jobs. So most people have insufficient income. And given the larger dependent population, although we have less child born, they get no increased support. They get insufficient support to achieve best human capital development and thrive. So it's like Thailand's first demographic dividend has long gone. We are stuck in between the second and third dividend that have not come. We have lower fertility and mortality rates, but these do not come together with increasing savings, investment, and human capital, especially among the elderly. And what I said is the overview of the country, but Thailand's inequality is extreme. So the situation is much worse for the household, children, and youth in low socioeconomic status households. If we look at the household with children and youth aged 25 years and below, we will see that the per capita income of the richest 10% is 20 times of the poorest 10%. And in this situation, children and youth are highly concentrated in the poor households, which usually have higher fertility rates. And so what we see is that 20% of children and youth in Thailand live in the poorest 10% households. And actually 70% of children and youth in Thailand live in the household that eligible to receive the poverty assistance benefits. But yeah, that does not mean they actually receive it. But yeah, 70% of Thai children and youth live in the household that eligible to receive the social assistance benefit. And moreover, another point that I think it's important for around the topic of inequality that impact their human capital development is that 40% of children in Thailand do not live with both parents. They live with grandparents or older relatives because their parents, their father or their mother, have to migrate out of the area to work in the urban area and industrialized area. So it means that most children and youth have no sufficient support financially or like from family support to achieve best human capital development and thrive in a time that such development is even more crucial for the country to benefit from the demographic shift and the demographic dividends. And it's sad that Thailand's policy have not addressed these problems or these loopholes adequately. The social cash transfer welfare is not universal and very much mistargeted. One example is the early child allowance, which is very important as investment, right? Because investment in human capital gets highest return of investment when we invest in the early childhood. But the early child allowance in Thailand is targeted only for children in poor household, but around 30% of those eligible do not really receive the benefits because of the ill system of the information in the government sector. So they cannot target the right target. The benefit cannot pay to the poor children inclusively. And the amount of these benefits is also too low. And in this case, for the child allowance, it is only 600 baht per month. So it's around less than $20, so which is impossible to cover basic expenses of early child care. And care services are also insufficient. So the number of child care centers is very limited and does not provide services for children aged below 3 years old. But the maximum length of maternal leave in Thailand is 120 days. So there's a gap between the point that the parent must come back to work and the point that baby is eligible to receive in the care center. So that explains why many children are sent to their grandparents in rural area to take care of. And these grandparents have limited capabilities to foster their well-being and human capital. So it is not a good start for lifelong development for youth in Thailand. And for the other public services such as public healthcare services and education services, Thailand does a pretty good in terms of the coverage of these services. We have universal healthcare coverage and we have universal free basic education, but the problem is their qualities and justice. For healthcare, the system is centered on medical treatment at the hospital, and it lacks sufficient primary care, prevention, and promotion services, which are very significant to long-term youth health issues such as mental health. And in this, so there are also vast inequalities in terms of service access and quality between rural area and urban area, between poor household and high-income household. So within these contexts, youth faces many health challenges that obstruct their human capital development. In Thailand, I think that we have to refer to at least 5 challenges. First, I think it is crucial to mention mother and early children's health. The rate of access to antenatal care and early child vaccination have been deteriorating since the outbreak of COVID-19 until now. Second, the air pollution. If you notice the air outside our venue today, the air pollution problem in Thailand is very chronic. In Thailand, almost 4/5 of days in 1 year have bad air qualities. So it causes short and long-term respiratory diseases, especially among children aged 10 or 9 below. It impacts development in other dimensions. It impacts the development of brains. Children cannot go to school or cannot play outside. So it impacts their physical, emotional, intellectual, and psychological development as well. Third challenge that I would like to touch is the digital screen addiction and impacts of AI usage from a very young age, which can affect their physical health, cognitive development, learning capacity, as well as emotional and psychological well-being. By average, by the research from the National Institute of Development Administration, Thai children start using digital screens since they are only 2 years old. So, and this is especially the case for low socioeconomic household with limited digital literacy. Many hardworking parents just give their kids smartphones or tablets as carers, so they can so the kids need no attention from them. And this is also the issue for grandparents who have no idea about these technology at all. Fourth challenges for youth health, I think it's the drug and substance addiction. Many Thai youth addict to e-cigarettes as regulation is not seriously implemented. The legalization of cannabis in 2022 also allows youth and everyone to use it almost freely in Thailand nowadays. If you cross the street, you will find the cannabis shop across the street. And the hard drug remains a pressing issue, and its price dropped dramatically, and it can be found so more easier, especially after the coup d'etat and the civil war in Myanmar. Last but not least, the mental health. According to our survey, 70% of youth aged between 15 and 25 years old report that they have issues about their mental health. They report that they somewhat agree or strongly agree that they always feel stressful. 50% feel lonely, and 20% feel not self-esteemed. And there are many calls for the government to invest more in consultation services, include them in the universal coverage. But the prevention and promotion, as I said, that are the weaknesses of Thailand healthcare system. So there is a loophole to support Thai youth health to thrive and to develop human capital in this context. I think another point that related to health challenge is the fact that 1 million school-age children are not registered in the school system by the statistic last year, despite the free basic education program. And you must understand that in the context of Thailand, the school provides access not only to the learning, but also the school lunch and milk that is very key to the poor children's nutrition, access to vaccination, and also access to health monitoring and guidance by teachers. The outcome of education is also a key challenge since every evaluation shows that a large proportion of compulsory education graduates lack even basic skills such as reading and reasoning. So in this context, with the ill-designed, ill-supported, and ill-prepared welfare and basic and public services, youths are ill-prepared to be the powerhouse that empower the civil economy and to benefit from the demographic shift and get the dividend for the Thai society. So for the first round, I think that's it. So thank you.
All right. So Mr. Boradon touched on challenges on youth as well as actually older people's well-being, welfare system in Thailand. In particularly the Thailand is aged before they reach. So there are obstacles for human capital development, old age support system, as well as social welfare problems. Inequality makes it worse, of course. So I teach actually labor economics on this topic as well, but I am very sympathetic to young people, especially they face slow income growth compared with, I got a job in 1980s. There are more jobs, and there was no AI. And that these days, actually, they face more precarious employment, labor market mismatch, informality, and also care responsibility for older people, and also mental health services remain unprovided. But they are surviving and educated. Okay, so next presenter is Pip.
Okay, thank you, Sangyop. At the beginning, I'm going to focus primarily on the second dividend, known as the savings dividend, but most of it won't be about health. So I apologise in advance to this audience, but you probably had a lot on health this week, so maybe it could be a relief for some of you. And I'm following my instructions from Sangyop, so at least I'm being a good boy as a panellist. If we think about the second dividend, so it's often called second or savings dividend. So the idea is, as people age longer, because they anticipate that, they save more over their working life, that feeds through the economy in terms of investment, and all kinds of good things happen, potentially. And I think it was pointed out by Asata, potentially is the important word here. So the potential sources there of some of this savings dividend I've got on the left: labour income, savings, family support, pensions. What we see in Asia and much of the developing world, as we heard from Africa as well, is that this potential is being compromised in many ways along the life course, and resulting then in outcomes in old age that are not realising there's some of this second dividend, and certainly not maximising silver economy or silver dividend. So for labour incomes, it's primarily due to informality and poor health along the way, which compromises productivity, presenteeism, absenteeism, all kinds of things, participation, compromises further human capital deepening. So all kinds of things flow from that. For savings and asset accumulation, we heard the Thai example, but it's true across the region. Even though aggregate numbers, and I'll show you those in a minute, don't look too bad for Asia, the distributional issue is a really strong one. So there's a lot of unrealised potential on savings and asset accumulation due to problems of financial inclusion, financial literacy and the like, and shocks which deplete savings. Family support, of course, if you had 6 kids, you could anticipate a fair bit of family support. If you've got 0.7 of a kid in Korea, you probably don't anticipate a lot of family support. And household structures, falling co-residence and the like. And then pensions, as we'll get into, it's an issue of low coverage, poor adequacy, etc., and sustainability in the long term. I just want to start with a couple of things, though, because if you think about older people and where they get to in life, you can look at the results and kind of think backwards. So one of the results is poverty rates. So this is on the left, the share of people whose incomes are less than half of median disposable income by age, and the orange bars are the older people. Only in India and Georgia, because of its universal pension system, are not poorer. But look at Korea. Sang-Yop's got a lot to answer for here, I think, for his older people. It's a particularly dramatic case, but the rest don't look great either. So on average, older people being poorer. The one on the right, and this came out, I think, a little bit in the other presentations, is the story of inequality in ageing. And we've looked a lot at this at our centre, and on the left is Malaysia, on the right is Vietnam. And these are birth cohorts, and they're within cohort Gini coefficients, so how unequal that birth cohort is. And essentially, the older that birth cohort is, the more unequal they are. Those lines descend exactly with age. So the youngest groups are at the bottom, the oldest groups are at the top. And this is a function of social protection systems, health systems and the like that are not providing mitigation of growing disparities across people across the life cycle. It's a very different pattern to what we see in OECD countries. In New Zealand, for example, my neighbouring country, the oldest cohort are the most equal. And in many OECD countries, they're more equal than their younger groups. So this is a very different pattern. If we then look at financial and kind of financial inclusion and the things that facilitate the savings dividend, or might, it's a kind of glass half full, glass half empty story. On the one hand, and that's the top left, there's been a lot of progress in financial inclusion at the surface level, more people banked, etc. And you see those numbers rising. They're still low in some countries, like Cambodia and others, but they're improving, and they're in some cases rapidly. But if you look at the bottom left, a lot of those people who are banked are not saving, and they're certainly not saving for old age. So you're getting the kind of appearances of financial inclusion, but not the economic benefits that would lead to a savings dividend. That's partly because of the top right, which is low financial literacy in countries. And the result is the bottom right, which is the share of households who have more than 2 months' worth of savings in the case of a shock. And you see in all countries in this region, it's less than half. In many cases, well less than half. Despite all that, as I said, the aggregate savings levels don't look too bad in these countries. In fact, some of them, like China, are well known for having high savings levels. So it's an interesting story of inequality, I think, where there is a lot of money and savings, sometimes savings gluts in the economies, but you get large shares of households with negative net saving. In China, about a third. In Thailand, about 60% of households. So it's a big distributional issue. And often healthcare costs and precautionary savings are a big, when people are asked why they save, that's a big driver of it. The second thing is work income. People in Asia work long and hard. I think on average, you don't need to worry about Asians working hard or long for the most part, particularly in the informal sector. What you do need to worry about is people in the formal sector withdrawing from work too early. So here we've got the blue bars are those of these age groups who are still working, and the numbers are pretty high in many countries. That said, though, there's still the yellow bars, which are the untapped health capacity to work. There's still a lot of people who have health capacity to work who are not working. ADB have costed what would be the economic benefits of that group from 60 to 69 working if they could, if they were healthy enough. And for some countries, that's quite substantial, almost a percentage and a half of GDP in Korea, for example. One reason that healthy people are often not working is pension systems, and that's in the formal sector, of course. Low retirement ages, pension eligibility rules which force people to retire. In China, you have to retire to collect your pension. You may stop working altogether, or you may go into the informal sector less productively. And labour laws and practices that don't encourage remote and flexible work. So you see there in China, I put on the right, the hazard rates, which are the kind of likelihood of retirement at different ages. And China, the big spikes for men and women come at the official retirement ages. For women, that's the green lines. Women can retire, well, at this time could retire at 50 and 55, for men at 60. And you see those spikes. On the bottom are rural households, who are all informal largely. And you see a much more natural, slower, graduated pattern of retirement behaviour. So really these big differences where the most productive people in the society are the ones withdrawing from the labour force the earliest, they're also the people who save the most when they're working. So it's a real, pension systems are not the sole cause of that, of course, but they are often with their current designs exacerbating that challenge in these societies. If you look at pension systems then, and on the left is the contributory, on the right is the social pensions or non-contributory, we get very low participation for income levels in many of the countries. What you've got on the vertical axis is the membership of contributory pension systems amongst the working age population. On the horizontal axis, the share of informality. And as around the world, it's a very strong relationship. If you're in the informal sector, essentially you're highly unlikely to be in the contributory pension system, and you see that relationship there for Asia as you do for the rest of the world. So low coverage there. As a result, very few people saving, or relatively few people saving through the contributory pension system, and so a missed opportunity on savings dividend. On the right-hand side, the response to that quite sensibly has been the introduction of social pensions in the region to say, well, we're not covering people in the contributory, we need to give them some support. So a lot of countries have introduced social pensions, but as you see there, the level of the social pension in Asia is really modest. I would have to say Asian governments on average are cheapskates when it comes to social pensions. Now, I'm not saying what an ideal number is, but you look at the way Asian countries cluster there, low coverage, low levels of benefit often in social pensions. So as a result, you have large proportions of population who get to old age with neither contributory nor social pensions. You see the distributional pattern of this. The green bars are the contributory system, the yellow bars are the social pensions. And as you would expect, very strong distributional patterns here. If you're rich, you're much more likely to be in the contributory system. If you're poor, you're more likely to, if get anything, get a social pension. But in either event, across the two of them, there's this large missing middle problem. If you look then at the design of the systems, you have a combination of defined benefit and defined contribution systems in the contributory systems across Asia. The kind of former Commonwealth countries or current Commonwealth countries, former British Empire countries like my own, were often with provident funds, defined contribution, and the other countries, civil law countries, often are the ones with defined benefit or pay-go systems. There's two different challenges here. For the pay-go systems, the challenge is sustainability. All the systems, China, Vietnam, Thailand, Philippines, Mongolia, that have DB systems, all of them face long-term fiscal sustainability problems, huge problems in many cases, for a variety of reasons. Their design, low retirement ages, generous civil service, they don't have adjustment mechanisms, sometimes low contribution rates. For the defined contributions, it's not a fiscal problem. They are by nature designed to be fiscally sustainable. It's an adequacy problem. So many of the people in those countries get to pensionable age with a very low accumulation because they were allowed to withdraw early for all kinds of reasons during their life. They only get lump sums in most countries. So in Malaysia, for example, where I've worked a lot, the majority of people have spent their entire pension by 4 years after withdrawal at age 55. So by the time they hit 60, there are no retirement savings left. So it's an adequacy problem in those countries. For different reasons and in different ways, both sets of systems are going to have to require deeper reform and more diversification of financing sources. Just financing from labour contributions in a rapidly ageing population leads you to a socially untenable situation where either you tax the hell out of this shrinking youth population over time, or you reduce benefits, or you do all kinds of things, none of which are politically palatable. So reforms are really necessary, and they'll be hard. So finally, just to wrap up, I think on this savings dividend, all the elements, given where, as was mentioned by Varadon, these countries have all either at the point like Thailand and China and Korea where they are already old, or they're rapidly approaching that point, Vietnam, Indonesia and others. So they're all going to be old before they get rich. Vietnam, for example, is going to hit peak working age population at 1/7 of the income of Australia at the peak working age population, at about 1/3 or 1/4 of the level of Japan and Korea at peak. So these are countries where demographics are doing their thing, but where the programs and institutions that are necessary to build savings across working life and assure financial adequacy in old age, which would be the source that will power the silver economy or could power the silver economy, are really lagging. And it's understandable. Institutions and policies take time to change. So do demographics, but they're just changing so quickly in this region that society, institutions and policies are not keeping pace. So as a result, you've got a lot of the building blocks. You've got more financial inclusion. You've got pension systems, social pensions, matching schemes, etc., but they're not keeping pace with the demands that come from ageing. Equally, the human capital development is lagging, again, not at the headline level, not in terms of participation often, but in terms of quality and in terms of things like adult learning. And across all those things, a kind of consistent challenge is inequity. That it's really these differentials and that the ageing is exacerbating them in the absence of sufficient policy change. And that's a real social, vulnerability of all these societies intergenerationally. One of the tools is pensions, as I mentioned, and clearly, more fundamental reform is needed to make them more equitable, sustainable, and as tools to be, contributing to potentially realising the second dividend and creating the financial base for older people to realise the silver economy as well. Thank you.
Thank you very much. So Professor O'Keefe's presentation highlights that harnessing the second dividend requires, as well as some of the silver dividend requires urgent policy reforms to address many issues, such as existence of large informal sectors here, adequacy, equity, and so on. Especially the labor and pension policies often disincentivize, right? It's kind of incentivize early retirement, and they are the most productive people. So the presentation calls for integrated market and pension reforms for active aging, which contribute to inclusive growth rather than rising inequality. So thanks so much. Our last speaker is Ms. Kanoko Ishii. She's the most probably, at least for me, close to the real world. So she'll talk about some innovation on healthcare.
Okay. Hello, I'm Kanoko Ishii. Very nice to be here. Thank you for inviting me. Okay, I'm going to talk about the Japan model. And where Japan is the forefront of the aging society. So we have a super age society, but we want to keep it very healthy. By keeping it healthy, it decreases the burden on the government. It decreases the burden on the society, and also by keeping people healthy, that leads to having more people, which whether they are old or young, contribute to building society and contribute to the economy. So a little bit of what we're doing, okay? A little bit about myself. I'm a Harvard Business School MBA. I was a partner at McKinsey, and then I founded Mediva. So I'm a business person. I'm not an academia person, sorry. And I also sit on government boards. I was on the deregulation committee and led the healthcare group during the COVID. I also sit in government committees for the Ministry of Health and Welfare and the Ministry of Industry and Trade. And Mediva is a consultant dedicated to healthcare, but we also have our own operation. So the things that I write over here, prevention services, health check clinics, primary care, hospital at home, community hospitals, daycare centers, whatever's, are things that we own and operate. And we learn from that. We try to develop innovation there, and then provide that learnings to the client, and also the things that worked or didn't work, we write papers and give it to the government so the government can think about it. So, and we do this in Japan, also in other parts of the world. Okay, and now talking about Japan. Japan has about 123 million people, and it is a very aged society. 36 million is over 65 years old. And because our life expectancy is pretty long, combined it's more than 80, so it's like 85 years old. So people live long, therefore, people get old, the society gets old. So one out of 3 people are over 65. That's Japan. And to cope with that, Japan had kind of started early to take care of it. In year 1961, we started a national medical insurance, so it's a universal health coverage. And we also, in year 2000, we have a national care insurance, and this national medical and care insurance, it's a universal coverage. It covers everyone in Japan. It's not just the Japanese nationals, it's the residents. So the foreign people who live in Japan, they are covered. And regardless of what type of work they do, whether they are working for a big company or they're farmers or they have part-time job, everyone is covered. Also the housewives who are not working, they're covered. And this medical insurance, of course, covers, particular surgery or cancer, those severe disease, but also covers things that support the elderly people. So the national care insurance would take care of senior residents or professional home care, people coming in to take care of people, or home renovation. And in terms of the medical insurance, that would cover like rehabilitation or hospital at home or dementia care. And this insurance, national insurance, is funded 50-50 by premium from the people and also from tax. And the copay is about 10 to 30%, depending on how rich you are. Okay, but more people, because we have a super age society, they would need care for sickness, frailty, and dementia. So the number of people with dementia is a little bit less than 5 million people. So 1 out of 7 elderly people in Japan has dementia. Pretty much. Okay, and therefore Japan, though we have very nice system, we have a lot of challenges. So these challenges would be like a rocketing medical and care insurance budget. We need more money to cover everyone. An increasing number of frail or disabled elderly people, increasing number of dementia people that I just mentioned, and there's an increasing number of elderly people living alone. And there is very large shortage of caregivers, caregiver workers. And these things is putting on burden on the family and society. So how do we deal with that? That's our big challenge. So what we're trying to do in Japan, though we cannot say that we're really successful yet, there's a lot of things that we're trying. So for example, using technology, high-tech Japan, bullet train, robots, whatever. And then, but not just technology, non-technology type of things like design or different types of healthcare system or even education. These things are things that are used and to improve quality and improve efficiency and try to keep the elderly people independent and keeping them healthy. Okay? And this is a chart that I really like, and it's used widely in Japan. This shows male and female, and there was this big group that Dr. Hiroko Akiyama studied, and we can see that 10% of the male is fit and independent till the end of their lives. About 20% gets really frail and need care around in the 60s. And 70% gradually drops. The female, unfortunately, none of these 10% fit till they die, but less in terms of getting their need for care in the early stage. So the key is, how do we grow this 10% male type of segment? How can we keep them healthy till end of life? That would mean that they will not need medical insurance money, the need for care would be less. So that's one of the things that Japan is really looking for. And some of the things that we're doing, there's a national action taken about, I think from 15 years ago or so, to prevent at an early stage to cure the chronic disease or NCD. At the age of 40, every year, every Japanese national has to go through a health check. And that would check whether you are obese or you have high blood pressure or diabetes and whatnot. Because if you are obese or have high blood pressure or have diabetes, that would increase your risk of having a stroke or those type of severe disease, which will lead to early stage need for care and also using hospital money. Okay, so after health check, this is for everyone, there's a mandatory counseling to change eating and exercise habits. And there's a lot of technology and education innovation going on, which I'm not going to go into details, to make change happen in people's life habits. So this is a thing that we're doing. And another thing is when people do get old, of course, most of them would have some kind of trouble, but having them living in place, which means that they would be living in their house or nearby senior residence, and being part of the society would keep them, at least mentally fit and also active And if they're socializing, they would eat well. They might exercise to visit their friends. And so this community-based integrated care system is obligation that each municipal government has to build within their within the neighborhood. And so there's a lot of things like exercise and rehabilitation, and also bringing people out of hospitals back into their home is another key big thing. Because if you keep an old person in a hospital, they cannot, maybe they get cured, but they can't go back home as they used to. They lose, their dementia gets worse, or they lose capability to walk, whatever. So there's a big national movement for taking patients out of hospitals back into their homes. So we have a home visiting doctor and nurse system, and we have a little bit less than 3,000 patients that we take care of, but there's many clinics and hospitals that does that. And not just curing taking care of people who are frail. We even have build system where we can cure pneumonia at home. And curing pneumonia at home, we have studied and found out that it is better for the elderly people, because curing part is about the same, but the rehabilitation of being at home is better at home. Okay, and Fujifilm has built a portable X-ray so we can diagnose pneumonia. Rehabilitation will be provided at the hospitals, in outpatient, and also in daycare center. I don't know whether this works. Okay, this before and after, same person. Kind of looks different, but it's the same person, believe me. Sorry, bad movie. And you can see that, the movement is much faster after 3 months. So this is a rehabilitation, and this rehabilitation is not done by therapists, it's done by care workers, because we have a manual and we have a procedure, okay? And you can see that this same person, same guy that you just saw, before and after 3 months, his posture is much better, and also exercise and nutrition. You can see that he got a little bit, plumpy. Okay, these things keep people fit. Okay, the elder people, and we also work in new technology, robots and sensors, and other things. This is something that Japan really likes. So we have what they call robots to assist people to walk, or we have air conditioners that would check whether the elderly people living alone is doing okay. We have little robots that would run around and be friends with the old people. So even if they have dementia, they can communicate with the robot. So we are doing that. And some of the technology that we're doing, I said this is still an experiment, but grandma who is living far away from their grandson, about 2 hours in the bullet train, can attend her grandchild's wedding. And this is not just seeing, but there's technology called haptic where you can feel. So she would kind of hug the bride. Okay, so this is still experimental, but these things are supporting the elderly people to keep social and feel good about their life, so that they can think that I want to keep on living. And I told you that there's a lot of elderly people living alone, and the family is living away, the government is trying to keep people from not leaving their workforce to take care of their parents, because that's the same phenomenon Asia-wide. Usually the daughters have to leave their work. But the daughters or the sons would be very worried, so we put in sensors at home. And these sensors capture motion, the grandma opened the door, or she slept well and whatnot. So the family can look at that and, feel secure. And also those data is shown to our doctors, and the doctor will say, okay, she's not sleeping well, or she is sleeping well, so let's adjust, the pills and whatever's. And these information, this is still experimental, but it's starting to happen all over Japan. Okay, not just technology, but also other things, like, for example, design. This is originally from Stirling University in UK. We took that in Japan, and kind of changed, UK design and Japanese design a little bit different. So we changed it and put into senior residents. Dementia people, because it's difficult for them to rely on their memory needs, and also because they would have bad eyesight and whatnot, as elderly people in general, or they cannot recognize things. They have problems which can be fixed by environmental design. So, for example, the black mat that you see on the bottom, dementia people look at that, and that will look like a hole. So they don't want to go out because, they don't want to step into the hole. But if you cover it with the same tone and color, people would not see that dementia people will not see it as a hole, so they can go out. Or how to put in signs that dementia people can recognize and say, okay, there's a toilet, I have to go. So these things we have proven, and Stirling University have wrote papers that these dementia design can keep dementia people stay independent. So, and these are put into senior residents and also in cities. Still a little bit experimental, but the city of Fukuoka in the southern part of Japan has put in that into cities. So even dementia people can walk out into the to subway stations, whatnots, and be independent. Okay. And the other part is how to educate the general public to understand how dementia people feel or see things, so they can react better. So we developed with Keio University an AR glass that assists people to see in the eyes of dementia people. And this has we received the year 2022 Healthy Aging Award for Asia with this. And it's widely used now to train, to educate people, okay? So the way these things work in Japan is that the national government sometimes fund the private sector like ourselves, or sometimes the private sector would think, okay, this is something that would become would be good for a society or would be a good business. So innovation happens, and the national government would pick that up, and then if it's a good thing, they would study it and then disseminate that to other private sectors or public sectors or other things. So this is, the way it works. And sometimes they would provide subsidy or do deregulation, or even put it into part of the national care insurance. Okay, so these are the things that's happening in Japan. We're not perfect yet, but there's a lot of things that we're trying and things that's working. And because Japan is in the forefront of the aging society, we do get calls from other parts of Asia. And I don't know, we learn from them, but they can learn from us. And, together we can build a healthy aging society. So if you have any questions, contact me. Thank you.
Oh, wow, okay. So Ms. Oishi's presentation emphasizes prevention, innovation, integrated technology, community-based care, and also public-private partnerships to maintain health and independence among older workers while containing costs. It's very interesting. And also, if you see, this session is organized this way. People who present gender, young people, older people, and from care, and also from different level of development, Africa, developing Asia, and most advanced countries. So it's very diverse, and we have we have about 35 minutes, but let me take a privilege as MC.
Yes, I think these is a very good questions, and if you look at general asset management, impact investment has received increasing popularity or increasing interest. But for pension schemes, I guess the challenge is that this is a public money, right? It's a collective investment.
Yeah.
And, the participants do not have choices. And this is you contribute to a scheme run by government.
Yeah, that's my Jekyll and Hyde part. Okay, interesting. So before we open the floor, well, actually, it's very interesting because I have actually many questions. I jot down many questions, but we actually didn't discuss any Q&A. But you know, that is a natural question, right? Let me see. There are so many questions I jot down. One is, we are talking about different level of development, right? So, for example, Thailand is and also other developing economies is aging before it becomes rich, and which tightens the fiscal space, right? And then, so how should policymakers prioritize between investing in youth health of well-being today and financing rising health and pension costs for older adults? I mean, that was my question for developing Asia. Then, after Ms. Oishi presented, my question is, this is Japan. Many Asian countries are aging rapidly without Japan's income level, right, or institutional capacity. So, which element of the Japan model are realistically transferable to middle-income countries or low-income countries? So, what I'm talking about is that every societies, every nations have a different focus, different problem. So there is no silver bullet. So I just want to hear about your, opinion from your country or your region, from African point of view, from developing Asia's point of view. What will be the priority? What are the policy? Kind of priority to make, active aging or harness demographic dividend. So this is very big question actually, but and especially when I heard it from you, the question is how this Japan model can be applied to the middle-income countries, for example. Okay, so anyone can start.
Thank you. And yes, thank you for this presentation. It was really, really interesting to see. I am, for example, impressed with the national care insurance, which means there is a real awareness about what it means and where we are going. So I don't know if it's transferable to Africa, well, I'm sure not, but it's really about what happened so that a society and a population became aware that we need to do something. This is where we are. I remember very well, I think it was during the 80s or something, we were talking about protecting the planet for the next generation. And I wasn't talking about unpaid care or whatever. It's very interesting in Africa. When I say 70% of the population is below 35, if I work with people of my age and above, and nobody is really moved, It's like, okay. So I say, okay, it means you take 10 people. There are 7 people that are below 30 and 35. And there are 2 people above 65, which means 1 is bearing all this. So when I say, okay, let's forget about protecting, who is going to pay your pension? And then people start to think. And when I talk to younger people, because I work with young citizen movements, and this figure really means something for them. So for me, I don't know what has triggered the fact that there is a need for an insurance for this future issue. I don't think it's transferable, but what I see in Africa is that when you're equipping people with what it means for your future, what it means that what you will have to bear with, it's working, it starts. The second thing that really struck me, what you said about the need for reforms and social protection, but also diversification of the source of financing for pension. It's interesting because you're talking about countries that are able to finance this pension. In Africa, less than 10% in the formal sector, and we are still talking about contributory social protection. 30% of the workers are poor workers. We have less than 10% in the formal sector, and we'll still call formal what is the smallest part of what is really happening. So for me, it's nothing about transferable, but raising the big question is, what are these systems that really do not fit to the reality of the society? It was not matching 10 years ago, 20 years ago. You all know, I think, at least in Africa, we are in that all stuff in aid, development aid, power shifting, localization, all that stuff, decolonizing. But this thinking about social protection for me is the biggest issue because it's not going to work. I started in social protection 20 years ago. We are still exactly at the same place. It's not working, not at all. And I was working on social safety nets with the World Bank. It's not working for caregivers. No, you're poor. Then you have access to social safety nets because you're poor. No, you are in the formal system, so you have access to formal social protection. If you're non-poor and non-working, which is a majority, there is nothing.
I mean, it's a big question, as you said, Sang-Yup. Maybe I'll just say a few things that I think might be relevant to it. The first is on this intergenerational trade-off stuff, which is, I think, we often characterise this from rich countries where the social setting is so incredibly different. Probably not so different in Japan and less so in Korea now, but you take a starting point in most of our countries where co-residence across generations is the norm. So you've got the grandparents, the parents, the grandkids all living together, and that's the bulk of people still in many of these countries. It's changing, but it's still. So start with that as the social reality, then talk about intergenerational tensions. It's a very different reality to where you have nuclear grandparents, parents, possibly children and stuff. So that's the first thing, is the notion of households and what that implies for intergenerational tensions, I think is very different. The second is that there's so many reforms that are win-win-win kind of thing across generations, subsidising childcare being one of them. You will get benefits for the families who want to have children. You'll get benefits for the grandparents who might otherwise have to care for those children, who might also be able to work. I won't pretend you will suddenly reverse the decline of fertility, but you might at least stabilise the decline a bit more. It's one of the more effective policies. So there are certain things that I think at the broad economy level and the all generations level kind of make sense. And, those ones, and most of them are good economics kind of things. If you look fiscally, at least across emerging Asia, by far the biggest fiscal risk is pension systems. If you look projections, health goes up, long-term care goes up, but pensions dwarfs most of them in the defined benefit things. So I think and that's, we all know that's really difficult to reform, but if that one genuinely is intergenerational, and I think needs a lot of attention. The whole financing thing, just to go back to what Asato was saying, the old model of, basing your whole social protection or your social insurance system on contributory labour taxes, as I said in my presentation, it just is not sustainable in a rapidly ageing society. And you saw that in Japan. It's 50-50 already in Japan. It's not because Japan's informal. It's not because anything. It's because the demographics have driven you to that point, and they'll probably continue driving you further in that direction. So I think we've got the whole assumption that labour markets would formalise more, that this model would suddenly become more and more relevant for more and more people. It's bogus. It's not bogus theoretically or in principle, just empirically. It hasn't happened in the vast majority of countries. China, it's happened a bit. There are exceptions, but even those exceptions are incomplete. The Turkeys, the Chinas, the Costa Ricas. So I think the whole thing of how we look at social security systems in ageing societies has to change. It'll sound like I'm boasting, it's pure historical fluke, but Australia started with a system that wasn't that at all. It wasn't like Europe, it wasn't social insurance. From the very beginning, we had a basic general revenues finance pension system for everyone. And it was means tested, it became means tested. We only introduced contributory mandatory systems in the 80s. So it was 85 years or so without any contributory mandated system. And surprise, surprise, you look at the OECD projections on pension systems, the only country that keeps stable pension spending is Australia. We've introduced superannuation over the top of that subsequently, so adequacy is protected. I'm not saying it's an ideal system by any means, but we flipped, from the very beginning, we flipped the notion that it's social insurance contributions that fund it, and that makes the system much more robust to demographic change.
Well, my point is similar to Professor Pip. Actually, because of family relations in Thailand and many Asian countries are very close. So the problems of the resource allocation between the welfare or investment for the old age and young age is not framed politically as generational trade-off. Actually, because of, I think, Thailand and many Asian countries, like the welfare or the benefits from the government is low for every age populations. So, and the problem of poverty is intergenerational. The poverty of lack of human capital development is intergenerational. And when the benefit is paid to one generation, it's shared in the family institution. So yeah, I think that it's not the question of how to prioritize, but it's the questions of how to balance the investment and the expansion of entitlement, welfare entitlement, and the investment in public services for all ages, because all are connected. Yeah.
Because I'm a business person, maybe I will be commenting from a different angle. I think what Japan has done in the past, there's things that succeeded, things that we failed in, and there's wishful thinking. So there's three parts. So one, in terms of what we succeeded is, I think Japan was not rich from the start. In 1945, we lost the war, and vast part of Japan was burnt. I mean, it was bombed, and there was nothing left. So we rose from that 1945, and then became a country which I think the thing that succeeded is developed a good middle class. People, there's rich people, there's poor people, and there is growing, rich people growing poor people, but there's a big middle class. And this middle class it's a steady class that would support the Japanese system. It would support the Japanese industry, whatever. And part of what worked in doing that is, of course, Japanese people worked hard, or we had industrial power or whatever, or we had technology from before the war. But the thing that I think contributed was the national health insurance system, because people that became a safety net. People don't have to worry about being sick. I mean, they can really look into the future and say, I'm going to work, and if I become sick, the government will take care of me. So that was very good. And the next step was the national care insurance. The national care insurance, of course, took care of people so that people can keep on working instead of going back home and taking care of their parents. But the other part is it built the business. If the government had not paid to the service providers, there was no industry developed. And when the industries develop, innovation happens. And at the end, the national medical insurance and care insurance does not cover everything. Meaning, like, for example, medical insurance, if you want to have a surgery using Da Vinci, that would be, you have to top that up. Or if you want to live in a very nice senior resident, you will have to top that up. But at least that would cover the basic. So that would provide a safety net, and also that would develop the industry. So that's the thing that worked well. And I think that should be, other countries that doesn't have the universal health coverage or the care coverage, I think even if it's not covering everything, they should think about doing something of that sort. The thing that did not work well, which might apply to some learnings for the countries that doesn't have the system right now, is that like for example, when we built the national care insurance, that was in year 2000. Year 2000, internet was barely happening. People do not have PCs, and smartphone did not exist. AI was not. No one even dreamed of AI. So if you look right now and doing the same thing in a more using technology, it can be done in a more productive way. You don't need that much money. You don't need that much people. You don't need that much paperwork. But unfortunately, the Japanese system is based on what existed in year 2000. So it is still very inefficient, and we're trying to break that, deregulate. But countries that are following Japan, they can start with a new technology. And the wishful thinking is the industry, the health insurance, health and caregiving industry that we're trying to build. And we do have a pension problem. Because old people go to boats, we can't change the pension system. However, the only way, there's two ways to solve that problem. One is inflation, which is not good. But the other part is to grow the economy. So how to build industries is, how to make the economy bigger is another way of solution. And that's what we're trying to do.
Okay, thanks so much. Actually, it reminds me of whether there is a first mover advantage versus actually later mover advantage. So actually, that's a good answer, because my question was stupid, but good answers. Okay, so we'll open the floor for about 20 minutes. So if you have any questions, and please say about your affiliation, your name.
Hi, thanks for a wonderful discussion. I'm Dr. Kate Telenko with Corvus Health, which is the social enterprise to give all people access to health workers. I have two quick questions. One is for Voradon. Tell us about these 1 million children not in school. Is this a transportation issue? Are they working in agriculture? Why aren't they in school? And then the second question is, could some of the panelists give us an experience of what happened when countries significantly raised retirement rates, the eligibility ages for pensions? Did people work until did people work until 65, or did they stop working at 60 and kind of make do until they could get their pension? I'm quite curious about that, because I hear all these people saying, oh, people are going to work longer. I don't think people want to work longer. So I'm quite curious about that. Thanks.
Okay, thank you for the question. I think there are many reasons for the number of 1 million dropouts in the last year. Yeah, one point is that the problem of poverty. The household have a lack of the means to support the students to go to schools, and the structural problems that that is behind these problems. One is transportation, right? Because the school is highly concentrated in some urban areas. So in the rural areas, school is very far from home, and transportation, we have no public transportation outside Bangkok. So it's the burden in terms of cash, and in terms of the family have to have some adult member to bring students to school. So it's another problem. Another problem is that this education system, the quality of education system is questioned by many students, many children. They think that it's useless to go to school. And many of dropouts choose to leave the school by themselves. Even they can go to school because the education is useless in their views. And this is connected to the context in the rural area of Thailand, that there is no job opportunities for the high-skilled workers. So even you graduated from high degrees or high qualification, you have no hope for high income jobs that needs high skills. So it's easy, like for many people, it's better to leave the school and find some income now, right? Yeah.
Maybe on the retirement age, I mean, I did put it up there. I think it's overemphasised and I think it's oversimplistic a lot of the time, the retirement age. I think the trend in OECD countries is either to eliminate mandatory retirement ages altogether, Sweden, UK and other countries. I think that's the first best, and build incentives into the system which allow people to choose, do they want more income from the pension system in old age or less, or work more, work less, that kind of thing. So I think that's the optimal place to end up. That said, from the fiscal point of view with defined benefit schemes, then it matters. So there's the labour market issues where I'm more sceptical that retirement age matters as much. It does matter, as we saw in those China figures. It affects behaviour. But I think it's, can be dealt with. But the fiscal side, at least in defined benefit schemes, that's a bit of a binding constraint. So you've got to deal with that. The other thing, though, just observation in OECD countries, the average age of withdrawal from work has increased gradually over the last 2-3 decades by a couple of years in most countries. They've also put retirement ages up. It's not the only factor influencing that. Better health and other things are too, but certainly it doesn't seem to have hurt.
I'm Marco Stampini. I am from the Inter-American Development Bank, which is the regional development bank for Latin America and the Caribbean. And I'm very interested in your point of view as a businesswoman, Ms. Oishi. So we try to work with countries to develop long-term care systems, but we also have a pretty solid silver economy initiative. And when I cross the care economy and the silver economy, we see that even in countries that don't have a public financing system, like the long-term care insurance system of Japan, there are lots of businesses that work in the care of older people. So set aside the financing area. From your point of view as a business person, what are the things that governments could do for these businesses to thrive? What other things beyond financing is needed to leverage this care economy? Thank you.
Other than financing, how to grow the silver economy business is, I think, your question. There are things that, there are, let's say, it does come to financing, but like what I mentioned, like the government providing grants to people who are in the innovation of silver economy, that would be something. And also sharing the experience worldwide. And also the government would put on, information in terms of these kind of services are available. And that is done at the national level and also at the local municipal level, so that people who need that services would reach out. So the government can kind of pay, not just for money, but kind of be the intermediary in terms of providing information among the business people and also with the consumers and the businesses.
Hey, hello. Thank you for the panel. It was a great discussion. I'm Leonard, a medical doctor and demographer from the University of the Philippines. So my question is, beyond mortality outcomes and service coverage, what metrics should policymakers use to assess whether a health system is successfully converting demographic change into economic gains? Thank you.
I think the fact that all these researchers are looking to me, and while you're talking about metrics, means that your question is a tricky one. I don't know about metrics. What I can say when I'm talking about this transformation, it means if this unpaid care work is not recognized, it is creating some disparities, okay? And for me, an example is that naturally, so in Africa, well, in West Africa, I will talk about what I know most. Most of the time, the two parents have to work because of the cost of life. It's just not possible, and because of the lack of proper, correct, or efficient public services. If there were good health system and good school, people, mother and father would not work. You have to pay if you want to grow an adult, a future adult that is able to be active in the economic growth. So now they have to work, and then you have your old mother that have diabetes. Somebody has to stop working. Most of the time it's a woman. That's not an issue. Culturally, we are born for that, and we agree because we want to raise our family. It's our traditional role, and it's really, we can really mix all this with our aspiration as working woman or whatever. But the fact is that because you are going to stop, you're not contributing or accumulating income, you are totally deprived of one of the first rights you have to be protected by our constitution, which means that this social protection that is supporting your life risk only linked to contribution and to the formal sectors is not protecting you. And what is interesting is that women in Africa are most vulnerable to monetary poverty, for example, and live older than their husbands and male. So it's a double punishment because you stop, you are not preparing your old age, your husband is going to die, and you will be a poor woman while you are assuming this critical social function to prepare the next generation and to support the next economic growth. So there is really this stuff about maybe some measurement about how this care is recognized as a labor and what it means. And very often the question is, what from some policymakers, are you asking us to pay our wife for what they are supposed to do? And we're like, no, because this is a big failure of communication. Nobody's asking for money. We're asking to be protecting, because it means no health insurance and no, even not about pension, no access to insurance or care. So one of the idea, and this is one of the NTA, so Professor Dramani is working with some countries to have a roadmap where it is recognized, and maybe why not to give a status to the caregivers. This is very complicated, but this is one of the key to give a real existence officially to these people that are supporting the next economic growth, actually. It's not a measurement.
All right. Gretchen, you have questions?
Ready? Okay. Sometimes it seems to me that achieving this sort of first and second demographic dividend is about a positive thing that the whole society can get. We invest in our children. We try to build up savings so that we can be more productive, richer. Everybody wins. Whereas sort of some of the silver dividend discussions is like, yeah, I keep you healthy and then I don't have to pay as much for you before you die. You know, that's sort of like I avoid a negative as opposed to sort of achieving this, you know, whole societal benefit. And so my question is, do you disagree with that? Or are your experiences of framing these discussions different? But what do you think would be sort of, if you do agree, what would be a better way to frame achieving these dividends?
Should I answer? Or? I mean, of course, there is no, everything has like a trade-off, right? So, I mean, achieving second demographic dividend, is a no-brainer. I mean, you know, if you are healthy, you can save, right, for future. But what actually, yesterday I talked to actually PM, you know, in European countries, you know, if there are enough pension benefit, you don't have to save. But actually what the reality is that rich people save and they receive actually high pension benefit, right? So, I mean, saving is good. And sometimes actually, so there are too much saving class. But I actually care more about the equity these days. So, I mean, there are people actually, you know, especially young people, I talked about that. I mean, the employment situation is very precarious. And even though you work hard, I mean, you cannot get a job. That's not their fault. So so then actually we just say you have to save. It sounds like very empty for me. So we have to provide some sufficient, adequate, at least some kind of social protection. So this is necessary. And the second question is, what is actually silver dividend? it's not about care, actually. It's more, it's not just only about care, but we want to actually make people more productive. We actually talked about this on yesterday too. These days, age is 60, I'm over age 60. I'm still chairing this session. So this age doesn't mean much probably in the next 10 years or who knows, because of deep learning, probably people will live another 10 years, very active. So we have to change the system. Actually Korea, many people believe that Korea's mandatory retirement age is 65. No, 60. They are one of the oldest nations in the world, but their retirement age is just 60. So the systems, we need reform. That's actually a conclusion. We need a reform. The society doesn't follow our logic or whatsoever, right? So, of course, there are many actually political economy behind that, but anyway, let me actually stop there.
I'd like to add something about what you just said and what the lady asked also. I think there is a difference between, today we are talking about labor and working. I think people want to be active. And if you're not working in a formal system, it means, okay, you're not active anymore. And there is some work that has been, the social accountability matrix integrating care that have been done in Senegal and Kenya are very interesting because, as I'm not, apologize, okay, I'm not, but for me, what was incredible, it was they just took all this economic stuff, said, there is two things, it's paid or not paid, it's care or not care. And I discovered that on non-care and non-paid, there is all that stuff that, I don't know, your great uncle that is cultivating something, somebody that is suing, and this is part of what is maintaining and supporting the families, not recognized, not bringing nothing. Another analysis in the same shows that the invisible solidarities, I think it was in Senegal, is 84 times more important than the visible solidarities. Because with all what I told about social protection, look at my region. It's not collapsing. Well, it is, but it's not totally collapsed. And which means that something is maintaining all this. And it's all these invisible solidarities, which the system does not recognize. So I don't know if it's working above 60, 65. Well, you have no choice. You are active. And there is a kind of productivity that is maintaining your food, your health, your clothes, but is not guaranteeing the fact that when you're sick, you're going to be cured, you're going to have access to medical care or health care or that kind of stuff. And for me, this is where also we need to think differently because not everything can be about contributing and through formal work, actually.
Could I say on silver economy, and I think of silver economy kind of narrowly, I guess, as older people as consumers. That part of silver economy, I think there are very clear spillovers to all age groups and the whole economy. In terms of labour demand for people who are going to provide those goods and services, in terms of GDP, and that AARP report from 2019 already breaks these things down, and most of the benefits are spread across all working age people in the broader society. So on the silver dividend, if you think of that as the extension of working life and the kind of productive contribution of older people, I think the debate there is often about, you always get it with policymakers saying, but if we get all these old people working, we've got youth unemployment and all the lump of labour kind of discussions that you get. That's an area where in emerging economies, in developed countries, it's very clear that what sounds like a trade-off is not in practice a trade-off. In emerging countries, I think there's a lot less evidence on that. There's studies from China that showed the similar result to developed countries, so that's encouraging. But I think we need more looking at that and seeing, does the same kind of positive dynamic apply as in rich countries?
Any other questions? Okay, probably this is the last question.
Hello, my name is Kwan Siri. I'm emergency physician from Chulalongkorn University. I choose this room because I'm interested about silver economy, right? Because silver economy is inevitable. As my role as an instructor in university, I believe in butterfly effect. I would like to share my idea, maybe just in case that it might like or maybe share other. So we faced with the uncertainty, and we would like to care aging people with sustainable, but we, as I'm an emergency doctor, we face with uncertainty with time pressure, disaster, and many things that we cannot predict. So I think why we funding and invest in the infrastructure like ICU, EMS system, and how many professional. But why don't we invest in the quality of team training, interprofessional collaborations, empathy, how to coping with stress, how to make decisions under uncertainty, because we face with uncertainty things. So we have to grow up the new generation next 10 years to be cope with this unpredictable uncertainty things. So I believe in stimulation, interprofessional education. I use team step for training undergrad, postgrad. I hope I can help WHO to reach Global Zero Harm 2030. But we have to start together, breaking silo, and we embrace some tools like team step to have a common language, to be communicate in the same language, not the communication failure like today, and we broken heart each other during pressure. So this is all I would like to ventilate in this room. Thank you for listening.
Yeah, thank you for your comments. Okay, due to my efficient management, we are on time. And why don't you just give a big round of applause for our panelists? Thank you.